Good morning, everyone. I'll be starting with the journal club presentation. I am Dr. Sandeep, currently doing fellowship on NBMS BPMCH. So the journal I am presenting today is on the Society of Thoracic Surgeons Expert Consensus Document on the Management of Pleural Drains after Pulmonary Lobectomy. It was published in Annals of Thoracic Surgery 2024 in volume 118. And the title is clear. It talks mostly on the uh, management of pleural drains after the pulmonary lobectomy. Even though it is written as an expert consensus document, it is compiled from various meta-analysis and randomized control trials. So we can say it is a on evidence-based medicine. It is a level A recommendation in every consensus that is used. And the information of authors has given as shown. Mostly they are the thoracic surgeons from the Massachusetts and Minnesota's Mayo Clinics and John Hopkins Medical Institutes. Before setting on the consensus document, they have asked themselves the questions. That is the objective of the document. That is to provide the guidance regarding choice of drains, including size, type, and number of the pleural drain, and also provide guidance in management, including use of suction versus water seal and criteria for removal, and imaging recommendation, including the use of belly and post-surgery chest joint X-rays, and the use of digital drainage systems and management of the prolonged ear leaks. So these are the 5 basic topics on which they have talked about. And starting with the introduction, pulmonary lobectomy is the most common thoracic procedure done for the benign as well as malignant cases, and the pleural drains are universally used intraoperatively and postoperatively for the drainage purpose. Yet the standardized guidelines have been lacking for the management of the drains universally. And care of these drains is the universal component of thoracic surgical practice. So this is the most essential part of our day-to-day practice. And uh, one one-way guideline would be most helpful in these cases. The Society of Thoracic Surgeons Expert Consensus Document provides evidence-based recommendation to optimize pleural drain management to improve the post-lobectomy outcomes. On the methodology section, so this is methodology section can be divided into two parts. That first is expert panel and literature review, and next one is the consensus development part. Expert panel and literature review are done by a thoracic surgery expert, which was convened by STS workforce on evidence-based surgery. And the key questions of chest tube management were defined, and then a Medline PubMed search for each English language article since 1990 was conducted till 2022. On the consensus development part, due to the limited comparative research, such as case control studies on these topics, an expert consensus was developed instead of an formal guideline with any ratings. And modified Delphi methods, which is the most used method to develop any policy, the consensus was used to develop the statements. So, starting from the choice of pleural drains, we have the traditional approach where two large bore or semi-rigid pleural drains can be used for long re-expansion. And the evolving practice, that is, studies suggest that a single chest tube or smaller flexible catheter may reduce pain and improve an early mobilization without compromising outcomes. So, according to the consensus document, in single versus two pleural drains, meta-analysis show that the single chest tube after lobectomy is enough, and it reduces pain, drainage duration, and hospital stay without increasing any ear leak or re-intervention rate. And the 11 RCTs that was given in the document shows no difference in single versus dual drains. And the no chest tube strategy is also evolving in some selective cases, but it has a limited data in anatomic dissection, and the consensus does not recommend omitting chest tube after the lobectomy. Another is the matter regarding pleural tube size. The smaller tubes, example 8 French, and larger tube like 28 French. Any tubes in between are used. And smaller tubes are shown to be associated with lesser pain score and shorter length of stay. And it is also shown for effective for hemothorax drainage in trauma studies, which is why the recent approach on putting the pictorial drainage is very high. And the larger tube, that is 28 French, is better for preventing subcutaneous emphysema, but there is no significant difference in narcotic requirements. So consensus recommendation is that 19 French to 24 French tubes for standard uncomplicated lobectomy, and larger tubes may be needed for extensive adhesiolysis patients with higher hemorrhagic risk. And another is the types of pleural drainage. The first one is channel drainage, also commonly known as a brand name Blake drains. This is the silicon drains. We can see the tip. There's a four-way channel at the tip of the drain. It is shown to lower the pain scores compared to the rigid tubes that we use. But it may require suction for effective drainage of the fluid, as the conventional pore tubes are more likely to drain effectively due to the siphonage effect. And the conventional chest tube, as I said, more efficient at draining air and fluid, especially in the presence of an earlet. Conventional chest tube are effective. So consensus recommendation is the conventional tubes or these expensive Blake drains is based on the surgeon's discretion due to the insufficient data. They does not recommend any special type of drains. So as of now, our takeaway is a single pleural drain, 19 to 24 French pleural drain, and the choice of the conventional versus the channel pleural drain depends on the surgeon's discretion. And also sometimes depends upon the cost and availability of the device as well. Now we'll talk about the management of pleural drains, and that is given by the experts. They have said the early transition to water seal and drain removal, that is what we are practicing. We are using the water seal and water seal drainage after the insertion of the drain. It reduces patient discomfort and length of stay. Other drainage strategies may be active suction strategy or active strategy, which may promote the earlier pleural effusion and resolve ear leaks faster. So a higher threshold of drain removal could help prevent pleural effusion and reduce the re-intervention rates as per different many RCTs. So the practice it varies widely. So it differs significantly across the surgeons and the local guideline of the institution. Despite the rigorous clinical investigation, there is no such set guidelines in these. So if we see the RCTs in water seal, just water seal drainage, several studies favors a water seal drainage with reduced time to drain removal and post-operative ear leak, and there is no benefit of the uh, uh, usual suction strategy, that is routine suction strategy, has no benefit found in the RCTs, whereas active suction shows it as a resolves ear leaks faster, but no consistent advantage has been found over the water seal drainage. So in suction strategies also, we have presented few weeks earlier, there is a dry and a wet suction strategy that has not been discussed in the consensus guideline. But in our setting, we have been practicing the suction strategy on a case basis where there is a higher ear leak or high or unresolved cavitation in the thorax. So if you see the RCTs, they have compared the water seal versus suction on routinely on day one, and the water seal group showed decreased time to drain removal and lower post-operative ear leak versus the routine suction drainage. So the European Society of Thoracic Surgeon guidelines, they does not recommend routine external suction for reducing ear leak or duration of the length of stay, and so does the STS guideline. And now if we see the digital drainage system, it is a battery operated device that we have had seen some few weeks back on our presentation. We use a regulated suction mode instead of water seal. Studies on different suction level have not shown any benefit versus the cost that the patient has to pay. And the consensus group opted against making any specific recommendation regarding the suction levels with digital system. And same with the channel drag, that is Blake drains, that is uh, Blake drain study have shown the Blake drains um, drains the lower fluid and air evacuation efficiency compared to the conventional rigid pleural tips. So there is no any recommendation for Blake drains as well. And another very important topic is drain volume threshold for the drain removal. Uh, so it has been said that the higher threshold for drain removal may increase the risk of pleural effusion, potentially requiring rethoracentesis. There have been many studies and they assume no yearly, non-bloody, non-chylous output before drain removal should be seek for before any drain removal. And the subjective nature of defining no blood, non-bloody output and the consequences of removing drains with the bloody output still remains unclear. It depends upon the institutional protocol. So, as per the many RCTs and meta-analysis, the consensus recommendation is that 450 ml per day or lower is endorsed as the safe threshold for the drain removal after the lobectomy, and many books even write the 4 to 5 ml per kg per day endorsed as the safe threshold. However, the a clear guideline is still lacking. So the takeaway from the drain management is that early transition to water seal is preferred over the conventional when a conventional chest tube and preferred versus the suction, the routine suction. And the drain threshold of 450 ml or less over 24 hours for non-bloody, non-chylous effusion is a reasonable threshold to allow safe removal of a pleural drain. And the another topic that has been discussed is the imaging recommendation. The earlier practice is the daily chest X-ray. So the STS consensus tries to look on the if the daily chest X-ray is essential or not. The pros is the chest X-rays are inexpensive and they are readily available. They are effective in detecting major post-operative complications such as hemothorax, pneumothorax, atelectasis, or even pleural effusions. But the cons is even these findings may not lead to any intervention as well. Which means there may be no clear clinical benefits for the patient, and many of these abnormalities may resolve spontaneously, which means we may have just added on the cost of the patient. Or sometimes the minor finding often leads to the additional imaging due to the daily X-ray protocol. So this is the RCTs that has been shown in the document. So 4 different RCTs in a total of 800 patients. So total of 2,000 patients. So no benefits on the daily chest X-ray. So other literatures, there have been 4 original studies, and they all have shown that the daily chest X-ray is not required. So conclusion across the studies is routine daily chest X-rays in stable patients do not provide significant clinical benefit. However, the chest X-ray may be done on a case basis or on the discretion of the surgeon. Another is the post-pull chest X-ray, that is a chest X-ray required after the removal of the drainage. And the key finding from literature is there are 3 retrospective and 1 prospective study totaling 948 patients, and only 1 study among them has comparable control group. And the conclusion of all the routine post-pull chest X-rays are also not necessary in stable patients who do not require a clamp trial. Clamp trial involves clamping the chest tube for 4 hours, observing clinical changes, followed by the repeat chest X-ray if needed. It is usually done for the cases where the ear leaks were seen earlier after the resolution of the ear leaks. So another topic is on the post-anesthesia care unit chest X-ray, or the routine chest X-ray that we do in the first post-operative day. There are 4 original studies conducted in this regard and 1 meta-analysis. In all these, the 48% in 1 retrospective study, 48% had abnormal chest X-ray but non-required clinical intervention, And in the meta-analysis also, only 4% of the chest radiograms were abnormal and 0.9% required clinical intervention, saying, leading to the consensus that routine PSU chest X-rays after lobectomy offer no measurable clinical benefits in a stable patient. However, the decision to obtain a chest X-ray should be individualized based on the surgeon's discretion. This also. So takeaway from the imaging part was that the daily routine chest X-rays are not required in a stable patient after lobectomy, and the chest X-rays after removal of the pleural drain can be safely omitted in a patient who is clinically stable and has not required a clamp trial. Another is the recommendation on the digital drainage system. The advantage is improved patient mobilization, consistency, and tracking of the ear leak data, and even the tracking of the amount that has been collected. And the limitation is pleural tube duration, that is, ear leak duration is not just the only factor for tube removal. Post-operative ear leak and the cost, that is added expense of the digital systems. These systems, they solely cost about £450 in UK, which is a significant amount of money in the resource limited settings. So these are the systematic review and meta-analysis comparing digital drainage and conventional analog system, and they have all shown the benefit to the digital with significant reduced on length of stay, hospital stay. The takeaway is that the drainage systems show potential for cost saving primarily through reduction in alloys and chest tube duration. However, the outcome is comparable to the traditional analog systems in effectiveness, and these guidelines, these consensus should have not kept this in mind in the resource limited settings. So we cannot say the applicability of this in our setting as well. Another is the consensus on prolonged ear leak, that is the ear leak lasting for more than 5 days after pulmonary surgery. So median length of stay has declined since 2000 to 3 days, according to the Society of Thoracic Surgeons General Thoracic database. And the key consideration in this regard is differentiating from bronchopleural fistula, that is the central ear leak versus the parenchymal ear leak, the ear leak from the stapler line, which is the most essential thing to find out before the management. So in prolonged ear leak, the management topics focuses mainly this consensus focuses on the management of residual ear space, safety of discharge with pleural drain, pleurodesis, endobronchial valve, and the evolving use of endobronchial valve placement in bronchopleural fistula, and then reoperation. So starting with the residual ear space, these significantly affect the ear leak resolution and may require the intervention as well. Some surgical adjunct surgical procedure like pleural tenting, pleurodesis, phrenic nerve blockade, or paralysis, and even pneumoperitoneal installation has been tried, and most of these studies are retrospective, small patient cohorts, and still require the high quality prospective data for the actual recommendation. So pleural tenting is the dissecting apical pleura of the endothoracic fascia to facilitate contact between the pleura and pulmonary parenchyma. It has shown, the RCT has shown it reduces the ear leak duration significantly from 2.5 versus 7.2 days in pleural tenting versus no active management. And another is discharge with pleural drains. There have been many studies. The main conclusion is that if a patient is to be discharged with pleural drains, it can be considered with closed outpatient follow-up. The risk is empyema, drain malfunction, blockade, or withdrawal. We should always weigh benefits and risks when deciding on the discharging patient with the pleural drain for prolonged ear leak. However, this should be done only after differentiating it with the bronchopleural fistula. Another is pleurodesis. The techniques are chemical versus autologous blood patch, and the consensus recommend autologous blood patch versus chemical pleurodesis due to the superior safety profile and effectiveness. However, autologous blood patch may not be applicable for all patients, especially in patients with the coagulation disorder. It is not of any use. So another is endobronchial valves, that is, it is used for palliation in advanced emphysema, also used for spontaneous pneumothorax and prolonged air leakage treatment. The challenges is two procedures in anesthesia, that is removal and then later on extraction. Another is the multiple endobronchial valves may be required for the multiple central airway leakage, and complication like pneumothorax from compensatory hyperexpansion, respiratory failure or valve migration is also there. And then another is the cost, where the document shows that the one endobronchial valve costs $890 pounds. Current recommendation is insufficient evidence to recommend endobronchial valves for PAL post-lobectomy. And another is the surgical intervention for persistent air leakage. That is, reoperation for persistent air leakage are rarely reported. Involves restapling, resuturing the parenchyma or applying the tissue sealants as well. There have been a largest report from a single center, that is 16 patients with the surgical intervention after the air leak. And only 50% of the cases, the air leak source was identified. In rest of the cases, they have only used the tissue sealants. And it also depends upon the availability of the resource, techniques, and expertise that is available. The conclusion is the reoperation should be considered when other intervention fails, but the outcomes are variable. But we should always look for the pre-surgical consideration, that is drainage system inspection. There is no system leaks, and bronchoscopic inspection to evaluate the bronchial system for potential issues. So if we talk about, so that is all that was written in the consensus guideline. If we talk about the strength of this document, it has provided us the comprehensive overview of the management of drains with evidence-based recommendation. And there is a high consensus group input that is collaborative insight from a diverse group of experts from different places, providing a balanced perspective, especially in case of the Delphi system, when the different surgeons are met in a place. If a surgeon has a very high renown in that area, this affects these type of guidelines, that is evidence expert consensus. So the blinding was done in this document, which was very good, and it is also clinically relevant. And the limitation is limited high quality RCTs and no case control study or very limited prospective study to make the recommendation is one limitation of the document. On future directive, there was an editorial done by the campus JL, which we have concluded that the active drainage system might be better, and the discharge with drain has a high risk of environment defaultation, and they have completely left the practice. Post-pool X-ray is must in their settings. Daily X-ray not required. It is a need-based, as written, as the editorial says. And autologous blood pass is good, but not for all, as the recommendation says. Thank you. That was it.
Thank you, Dr. Sandeep. The measuring the level of the fluid in the Eurobag system, the plastic bag system, is accurate. You cannot accurately measure. So this is the next time. You don't need to clap. You can measure. You can keep it. There will be generate two bottle system with 1,000 ml, 2,000 ml. You can measure it very correctly. So that's the next thing. There are variations regarding putting from the zero post-operative day, whether in the underwater seal motor only or to the suction. So the earlier practices all over the world was to put in the suction, minus 15 centimeter water. So always, whenever they connect, they always used to put in the minus 15 to minus 20 negative change suction. The underwater. But right now it has been changed because there is no difference, even the statement and so on. So the good conclusion was that it depends situation to situation. The best habit will be to keep underwater seal first. Then if required in the post-operative period, if you find there is a residual space, or you find there is a excessive surgical emphysema, then you can keep it under suction, otherwise it's not required. So it's a case-to-case basis. We start with simply underwater seal, then if required, we can put it in suction. So keeping the suction from the beginning may not be a good habit, And that we have been practicing also. We never put from the zero cost of India antibiotics in suction, we just water. Regarding the digital drill, we don't have this. So digital drill system is very good. It's expensive, but it's very good because patient can carry. You don't need to attach to the suction. Everything is motorized inside. There's the digital system of measuring, and you can have Wi-Fi based monitoring of what's happening with the patient, what's happening with the chest tube photos. We don't have to don't talk much about it. When the brain removal, it was still since a long time it has been still a debatable fashion. What we said, what our teachers taught us, 150 ml or 200 ml, less than that you can remove, provide us non-blood bloody, no pulmonary, no ear leak, and no kinase effusion, then we can remove it. But right now, before this consensus in our department, we had the statement that we remove from 3 to 4 ml per kg per day. But now the threshold has increased. They say even up to 5 ml per kg per day, we can remove it. So this would have the only drawback is that you keep an eye on those patients because the patient might develop re-effusion inside. That's what Dr. Anup had asked us. So if there is a reaccumulation of the fluid, some cases it might happen, then you have to do the ultrasound, not necessarily the chest X-ray. Ultrasound can detect it, and if the patient is symptomatic, you can do the thoracocentesis of case-to-case basis. That's, I think, is good consensus. But right now, we have been following the policy of 3 to 4 ml because our patients might be different from the Western society patients. Those infrastructure that they have, we don't have this. So we are a little bit afraid, reluctant to be sticking to the 450 ml per day for the drain removal thresholds. We still keep to over 3 ml per kg per day, or roughly 200 or 250 ml per day will be quite good for the drain removal. Next was the imaging. The routine, I was also quite surprised. The routine practice was daily chest X-ray. We don't do daily chest X-ray. So the best answer is on-demand chest X-ray. Right? On demand when it is required. What we have been practicing on first post-operative, we do the chest X-ray after lobectomy, or what we decorticate to see what's the expansion, what's going wrong inside, right? So we have been practicing that, and on demand we do the chest X-ray. Definitely our practice was before removal of the chest, and we do the chest X-ray in our department. But the consensus states that it's on demand basis, so you do on demand. After pull-up, we generally don't do chest X-ray in our department, but the statement has been also the same, that you don't need to do chest X-ray even after removal of the chest ray, right? Chest ray. Regarding the pleural prolonged ear leak, this is a very good thing that I have come up with. Regarding the prolonged ear leak means if something leaks for more than 5 days, we call it prolonged ear leak. So how we are going to track with that? That's a very good point. So this prolonged ear leak we divide into alveolar leak or parenchymal leak or the bronchopleural fistula. So regarding the bronchopleural fistula, if it happens early days, then there's no option. If it's the minor, for example, we can do some sealant with the bronchoscopy, find out the opening, we put the glue and then seal it. But if it's the dehiscence, major dehiscence because of the staple misfire or something, or some of the major leakage, then we have to take the patient for resurgery and we have to solve that problem. Otherwise, the rest alveolar leak, generally if the lung is expanded, we don't need to be very much afraid of. So before it was said, do not remove the chest drain if there is the air leak. But right now it says, let's suppose the lung is completely expanded. You waited for 5 days. Still there is the air leak. You waited for 10 days another, thinking that the air leak will stop. Again there is the air leak. You did the priority system. Again there is the air leak. Then how long you are going to wait? So the answer would be, if the lung is fully expanded, there is the air leak. We have waited for sufficient time, even after the pleurodesis. If it's still there, then you do the clamp test. You clamp the chest tube, wait for 4 to 6 hours, do the chest X-ray, look whether the patient has become symptomatic or not. If nothing is happening, then you can remove the chest. So it's not much that the ear should have stopped before removing the chest tube. Only thing that the lungs should be completely expanded, and clamp test has been done to prove that patient doesn't become symptomatic, or there is no reaccumulation of the air causing some pneumothorax. So that should be the answer. So regarding the surgical management, they said that when we predict they said about the pleural tendon, right? So pleural tendon, I'm not in favor of pleural tendon. It is done basically after the surgery, when the patient has got the residual cavity due to resurgery, and you don't have any tissue material to fill inside, then the pleural flap or pleural tendon will be removed. Besides that, for the prophylaxis of the residual cavity in the post-op period, it is not done except in one condition. Like you have done the lobectomy and the lung is inflamed or bullets are there in the remaining lung. It's leaking. And there is a huge space, it's not expanding on the positive pressure by the anesthetist. So at that point of time, during the surgery, check the pleural flap and cover it. That could be one of the good things that you do for the prophylactic purpose. Otherwise, routinely it is not done. The pleural thing. Definitely, after surgery, the big question is how to manage the residual space when you have after lobectomy. Like we have the patient in our work, right? He has got the lower upper lobectomy, right?
Oh, the right upper lobe.
Lower
Right upper lobe.
right upper. So we remove the right upper lobe, and in the post-operative period, he has got the residual space. He is asymptomatic, but there is the big space. I think 1/3 of the human space. He is asymptomatic. Then how you are going to achieve it? The only fear from our side is that this potential space may convert into empyema. Pus may accumulate that completely. That's what we are being afraid of. So in these cases, there is no ear leak, that patient. How we managed, because we saw this chest X-ray on the first operative day, then on the second, third post we repeated, it's still there. So because of that, we put under ultrasound guidance the picture drainage here. We attach this picture drainage to the substance. Now it's resolving. So in such cases, if we do the CBC, WBC is not rising, no fever, no ear leak, then we can remove. Because this potential space eventually will convert into the fibrothorax, the space will be resolved by itself. Nothing to do. Only one minor point I would like to say is they mentioned the pneumoperitoneum. To have any idea of what the pneumoperitoneum is used. This is a very good point. So let's suppose the patient has got lobectomy and lower lobectomy, and he has the pneumo here. That's not getting resolved. There is the fear the patient will develop the empyema. There is the ear leak even. So the drain was inserted, the ear leak is still, the lung is not expansion, there is the space here. So what do? You have the option of resurgery, don't want to take the patient for resurgery. The very good option would be to insert the pneumoperitoneum, even under IV sedation or local anesthesia. 300 to 500 of air, not CO2, will be inserted and wait for 24 or 48 hours. And generally it will resolve because the diaphragm will be stopped, and because of that, this cavity will be replaced and it will diminish the cavity. So that will help. But for that, you should be quite sure that there's no cortex which is compressing the lung. This one thing. Even there's the minor cortex that will do the work because the diaphragm will be there, it might be dead here, actually here. And that's the only thing. There is no intraoperative adhesions in the abdominal cavity. For some reason, the patient has gone laparatomy beforehand. There are some adhesions that pneumoperitoneum may not work. That's the another reason. Otherwise, the pneumoperitoneum in early days, if it happens after 1 month of time, then there will be the fixed diaphragm that will not be beneficial. So in the early post, like 2 weeks, 3 weeks of time, there's the good option that you may try the pneumoperitoneum. So I think with this statement, we have to change our few practices in our institution also, because this very relevant topic, and we have to stick with that. So most of the things we have been following us in our department. So we should be very careful in keeping the chest in. I think we have to start with our own study also, what's happening in the place scenario. We have been doing keeping the chest in for various reasons. So this is an eye-opening that we can do our study in the place scenario. So what's happening? What should be our threshold? How often, if we try to remove at 450 ml, how often the patient requires rethorax synthesis? And And very good thing will be that no tube is always better, right? No tubeless surgery, no chest stent. That will resolve all this. The caveats of having the things that have been explained here. So that has not been shown by this, various documents, and they still recommend that tubes have to be placed. Tubeless surgery, they still do not recommend. But that's the future. I think the tubeless surgery, the era will come. It is very good. It is being practiced in several centers. Several centers in China. It's very popular. So I think our future will be also tubeless surgery, no tubes. So any comments, any question? I think this was a very relevant topic. Okay, sir? Well, thank you, Sandeep.
Thank you, sir.